On behalf of PHA Canada and Scleroderma Canada, welcome to our webinar on pulmonary hypertension and scleroderma. We're going to have two speakers today. First, we're going to have Jane McLeod, who's one of our patient partners. Excuse me. And then we're going to have Dr. Nathan Hambly. So I'd like to introduce our patient partner, Jane McLeod, who's living with both pulmonary hypertension and scleroderma and has agreed to join us today to talk about the experience. It might take us a second to get Jane up, so please be patient.
There. Is that it?
That is it.
Okay,
Go
good.
ahead.
Thank you. Okay. Hi, everyone. My name is Jane McLeod. I was diagnosed with both scleroderma and pulmonary hypertension in July 2020. Um, I had, in hindsight, which now I realize it's not a very good hindsight, or hindsight isn't very good. I had scleroderma for many, many years prior, to the fact that it affected my lungs and I developed the pulmonary hypertension. Um, and 2020, it just happened to be during the uh, COVID pandemic too. So um, getting a doctor's visit was nearly impossible. I could talk to them on the phone. They couldn't see me. Um, they asked me questions and things, but it just wasn't good enough. But the years prior, when I say that I had scleroderma prior to this, was I had many, many broken bones in my life. I think my first one was in 1988. I was just standing on skates helping my son who has a disability, just standing there, and a little girl pushed me, and I fell and broke, did a spiral fracture to my leg, and and then I'd had many broken bones after that, and had osteoarthritis diagnosed, and had knee replacement, both right and left, and ankle replacement, left, very severe. That's awful, and broken wrists. Um, and also I was finding I was getting very dizzy, and I would fall in the house. Just after I got up to go to the washroom or whatever, I would just drop. Um, and I was having increased shortness of breath, and uh, I just couldn't walk any distance at all, and without getting very, very short of breath. And at one point, my sister-in-law came over, and because she was talking on the phone, and she's a nurse. I was a nurse too, but she was a nurse as well. And we tried to walk a bit outside, and I just couldn't do it. And my O2 sats were very, very low. And but at this point, with doctor's phone calls, I was booked for an angiogram at our local hospital in Peterborough. And I decided to wait till I had the angiogram before I went in. I probably shouldn't have. I should have gone right in to emerge. But anyway, I went in, and they did a double angiogram, right and left heart. And I was after it, I was sent to intensive care for 8 days with the pre-diagnosis of pulmonary hypertension was what the doctor thought. And I was in heart failure actually, so on IV Lasix and things like that. And after 8 days, they sent me to Toronto General in an ambulance um, to be treated again for more pulmonary hypertension. And that's where the doctors, residents, nurses, therapists came at me for scleroderma. I was just almost like a guinea pig. People were looking at me left, right, and center. Um, I had little marks on my face that I had mentioned to my family doctor a long time ago, and she thought it was maybe from a moisturizer. And sore fingers, Raynaud's disease, and those were overlooked. Anyway, in Toronto General, I got the clear diagnosis of scleroderma, and they said that the scleroderma caused the pulmonary hypertension. Um, It's uh, it's a long process. Having both diseases, trying to follow the rules, limit my fluid intake, limit my salt intake, exercise. I go to the Y mostly 5 days a week to do some kind of exercise. Um, I'm on oxygen now since 2022. My mobility in the last year decreased, and I was having to use a wheelchair more often. Um, and but with I'm working really hard. I'm doing some physio, and I have a walker that I'm able to use more often now. So that's good. And I've started on well, I'm on the Remodulin for the pulmonary hypertension sub-Q continuously, and I was lucky and blessed to be put on Sortacept on a, a compassionate basis, which I'm really happy about. I've just started it 3 weeks, every 3 weeks. So I've only had my third shot, but I am starting to feel better. But the scleroderma continues to be an issue with my swallowing. I have really bad swallowing. And because of the pulmonary hypertension, they can't investigate because the risk is too high, like for giving me any kind of sedation. So I'm just trying my best to, eating soups and small bites and things like that. My skin is affected. Oh, my bowel, yeah, you name it, it's affected. Um, anyway, I feel I'm doing better, and I'm so glad I have a more clear understanding of both pulmonary hypertension and scleroderma. And I will continue to do my best for myself and for others. Thank you.
Thanks, Jane. We really appreciate you sharing your experience. And I hope you feel better and continue to do well too. And now I'd like to introduce Dr. Nathan Hambly, our other presenter today. Dr. Hambly is the clinical lead of the Firestone Institute Pulmonary Hypertension Program at St. Joseph's Hospital and McMaster University and works as a consultant respirologist at St. Joseph's Healthcare Hamilton. His clinical interests include pulmonary hypertension, interstitial lung disease, and sarcoidosis. We're very glad he agreed to put together his presentation for us. Over to you, Dr. Hambly.
Thank you so much for the invitation. I greatly appreciate it. And thank you obviously to PHAC as well as to Scleroderma Canada for the invite here today. So I will just share my screen. And is that presenting okay?
Yes, it is.
Great. So today we're going to be reviewing and understanding the connection between pulmonary hypertension and scleroderma that certainly with what Jane has said is linking those two conditions and talking about sort of the nature of the disease as well as the treatment options that are available. And Jane has mentioned Remodulin, so sotatercept already, and we'll go into detail regarding those. So the objectives for today are first going to obviously discuss scleroderma and how it can affect the lungs. And then we're going to sort of do a little bit of a primer, pulmonary hypertension 101, and specifically focusing on how is it diagnosed and why do doctors do so many tests. And then we're going to just briefly outline the novel existing and also the novel therapeutic strategies that we have for treating pulmonary hypertension. And basically, all the drugs that we use to treat pulmonary hypertension can also be used to treat scleroderma-related pulmonary hypertension. So for those in the group who aren't familiar, when we talk about scleroderma, scleroderma has two names. It can be called scleroderma or it can be called systemic sclerosis. And I'm not a rheumatologist, so I don't go into too much detail in terms of the difference between those two. But if you look at it in terms of what does this mean, sclero comes from the Greek meaning hard, and derma is Latin meaning skin. When you think about scleroderma, it means hard skin, but really what it's talking about is sort of the glue that holds the tissues together. The connective tissue itself becomes much more hard and thick and stiff. And that's what causes the changes. And certainly, classically, it was known as involvement involving the skin and the hands, but that type of hardening can happen in many different types of organs. When you use the idea of systemic sclerosis, it's basically the same thing, but in terms of focusing more on the generalized whole of the body rather than just focusing on the skin itself. And certainly this is a disease that it's been around for a while in terms of it was described something similar by Hippocrates. And in 1945, its association with a systemic disease involving the lungs, the heart, the gut, and the kidneys, and all the different associations were described. What is it itself? Is basically it's a disease where your body's immune system goes wrong and ends up attacking the small blood vessels in the lung, as well as the that tissue that holds the glue that holds all your tissues together itself. And when we're talking about your immune system, so your immune system is usually there to fight infections, it fights bacteria, it fights viruses. It also looks at is involved in wound healing. It's also involved with fighting cancer cells. So your immune system orchestrates all these different important things. And when it goes wrong, it can cause these autoimmune diseases. So type 1 diabetes is an example of an autoimmune disease where your immune system is targeting your pancreas. A lot of people with thyroid disease, that's autoimmune thyroid disease, where the immune system is targeting the thyroid. In scleroderma, it's targeting the blood vessels in that matrix that holds everything together. And so certainly we know that there's this immune dysregulation. We know that it affects blood vessels. And as a consequence of this, it causes fibrosis or scar. Fibrosis and scar are two things that go hand in hand. But what's important is that there are many unanswered questions about all the other things that tie this together when someone comes and say, well, that's great that I have this diagnosis. We've established that, but why? And that's a critical question that involves both we suspect genetic associations as well as associations with environmental exposures, whether or not diet is involved. There's a lot of different things that go into that are currently under discovery. But when we're talking about these cardinal features of the effect of the blood vessels, the scarring, and the associated puffiness and affecting that glue, you can look no further than look at someone's fingernail. And in some patients, we can see that there's these changes. So patients are often somewhat struck by, they come to see a respirologist or a lung doctor, and most of the time I spend looking at their hands. And what we're looking at is specifically looking for these changes that would signal that the patient has scleroderma as the cause of why they're presenting with pulmonary hypertension, or in my interstitial lung disease clinic, it could also be related to that. So when we're looking at the organs that are involved in the setting of scleroderma, we talked a lot about the skin, but it can also involve the joints. It can involve the muscles. It can involve the kidneys, the gut, the nerves. And what we're going to focus on today mostly is in scenarios where it can involve the lungs and the heart. So when you see a slide like this, it's very disconcerting because if you're just recently diagnosed with scleroderma, it's like, whoa, wow, all these things are going to go wrong. How is this going to impact my overall quality of life and where we go next? And what's critically important is that there is a very wide variety of presentations of individual patients in terms of what symptoms they experience and what organs are involved. And what we're learning more and more is that there can be some very almost silent cases where the skin is very minimally involved and the predominant involvement involves the heart or the lungs. And so you don't get the systemic sclerosis part of it, but you do get the organ part of it, if you will. And so what's really important is that you have to look at each individual patient as sort of a unique case and trying to tailor therapy as appropriate to that person. We mentioned a lot earlier in terms of when we're talking about scleroderma, what type of things are we looking for? So Raynaud's is in the top left image where you can see that an area of the finger is losing blood flow. And as a consequence of that lack of blood flow, the finger becomes quite pale. And it's often that clear line that demarcates normal from abnormal. You can see there. It's often related to exposures to cold air, cold temperatures, cold water. Emotional changes can sometimes be associated. You can have the thickening of the skin that you can see in the top right image. And then we have these abnormal telangiectasias, or these lines that are blood vessel changes that Jane was describing, that can happen on the fingers, the face, sometimes on the chest, that are related to abnormal blood vessel growth. But again, not every patient presents in this clear-cut way. So it's important that we always keep a very open mind as it relates to each individual patient as a unique entity. So now switching from scleroderma to just talking about the lungs as a whole, what's really important is whenever I'm talking about lung disease, I try to describe the lungs as a big maple tree. I think the leaf here is probably an ash tree, so it's somewhat different, but bear with me if you will. Is that you have a trunk, which is your trachea or your windpipe, and what happens with those trunks is that they branch, and they branch and they branch and they branch until you get to the outside of the lung where there are leaves. And it's where in those leaves where all the magic happens. That's where the oxygen gets into the body and where the carbon dioxide gets out. And our body uses that oxygen as a source of energy to make everything work. And when we're dealing with different types of lung disease that are affected by scleroderma, it primarily affects those leaf structures. And when we're looking at the lungs themselves, on the right is a chest x-ray, on the left is a CAT scan. You can see that the heart is sort of situated in the middle there, and then you have this branching trunk coming down in this enormous surface area that's created where that magic happens. If we look specifically at the blood vessels, you can see that the blood vessels basically go wherever the branches of the tree go. And that those blood vessels follow the exact same pathway and create the same type of branching pattern that feeds those individual alveoli or leaves that where that gas exchange occurs. And when we're talking about pulmonary hypertension, specifically our blood vessels in our lungs are usually, obviously they're round, they're cylindrical, and they're very low resistance in terms of low resistance to flow to allow fluid to go from the right side of the heart into the lungs very easily and smoothly. When you look at in the setting of pulmonary arterial hypertension, what happens is that that vessel becomes narrowed, and it becomes narrowed not just because it's constricting, but because it's the smooth muscle layer around that sort of forms the tube itself it can become inflamed, it can become scarred, and you can get these different types of issues that develop within it that cause that to become progressively narrowed. And just like any type of plumbing, if you cause progressive narrowing of whatever tube you're pumping through, what happens is that puts a strain on the pump that's trying to pump that volume of fluid through. And when we're talking about pulmonary hypertension, that involves the right side of the heart or the right ventricle. So this is sometimes the forgotten child when you're talking about the heart, because when you're talking about heart attacks, arrhythmia, all these things, that involves the left side of the heart predominantly. But what we're talking about specifically is the right side of the heart, because the right side of the heart is the side of the heart that pumps blood through the lungs. And when patients develop issues with progressive shortness of breath, leg swelling, these types of symptoms, it's because the right heart is beginning to really struggle. And this is an electron microscopy image that's looking at the blood vessels in a normal patient and contrasting that in the setting of pulmonary arterial hypertension, where those blood vessels, there's less of them. And you can sort of see like sort of these almost like fern-like extensions that come from this, is that they just sort of become, they're losing some of their foliage, if you will, to stick with sort of a botany analogy, and that they're becoming pruned. And as a result of this pruning, you can see that obviously that there's less surface area to pump that blood through. And when we're looking specifically at scleroderma, obviously we talked a lot about blood vessels, but if you're using nail fold video capillaroscopy, certainly you can see how these blood vessels are abnormal in the setting of scleroderma as well. So certainly there is a linkage between scleroderma and pulmonary hypertension, specifically as it relates to the involvement of the blood vessels. When we're talking about symptoms associated with pulmonary hypertension, one of the major struggles with pulmonary hypertension is that the symptoms are very nonspecific. If you look here and we're looking at the different types of symptoms, we're looking at fatigue, lightheadedness, shortness of breath, maybe some leg swelling and fewer patients. But the most important symptom that patients describe, and certainly what Jane described, is related to shortness of breath. In terms of physical exam, really, certainly as a respirologist, I always like listening to the lungs to see if there's any abnormal findings. But especially in the setting of pulmonary hypertension and in scleroderma, where you learn the most about the patient, obviously, when on physical examination, is looking at the hands and looking for these characteristic changes that you see involving such. Um, Many in the audience will be familiar with pulmonary function testing, where you go into the breathing booth and have the respiratory therapist coach you through doing all the maneuvers that are required. And I know very well that it is often uncomfortable and it's not necessarily quote unquote normal in terms of the type of breathing mechanics that you're doing, but the testing gives us very important information in terms of how well those leaves or alveoli of the lung are working. Our primary screening tool that we use to diagnose pulmonary hypertension is the echocardiogram. This is the ultrasound of the heart. This happens either in a private clinic or in your hospital, where they slap on the ultrasound jelly and they're taking basically these pictures of the heart where you can actually get a sense as to how the right ventricle or the right side of the heart is functioning. And you can also get an estimate as to whether or not the pressures are elevated on the right side of the heart. What's important is that guidelines recommend, and this is obviously important for patients to know with scleroderma, is that we usually want to aim for doing one of these breathing tests or pulmonary function tests or ultrasounds of the heart on a regular basis. Sometimes it can't be facilitated on an annual basis, but we want to keep in touch. So it's important that if they aren't being done routinely, to maybe speak to your provider in terms of, well, if it's not being ordered, is there a reason why, or different things along those lines. So it's always important to keep that in mind. And then once you have an echo that shows the abnormality, subsequent to that, obviously, patients get referred to a specialist. And what does a specialist do? And I know patients are often frustrated with me to a certain extent, is that we have our wait list, you come see us, and the first thing we do is we order more tests. I try to give as much information as possible, but the thing is we need this information in order to guide our subsequent therapies. And in terms of one of the things we routinely order are CAT scans, which are basically very detailed x-rays of the lung, so we can actually look at what the lung architecture itself looks like. This is someone who has interstitial lung disease, where the leaves of the lung become progressively scarred. This is also a complication that we see in the setting of scleroderma. So it's important, especially for our patients with scleroderma, that we evaluate this. And then certainly the key diagnostic test that needs to be completed that Jane mentioned is related to doing the right heart catheterization. So the right heart catheterization is the procedure whereby we actually measure the pressures within the lung to know whether or not the pressures are high. Certainly, it's easy enough to put a blood pressure cuff around the arm and measuring the blood pressure that way, but that's measuring the blood pressure on the left side of the heart. What we want to do is measure the blood pressure on the right side of the heart and in the lungs. And the only way we can access it is through the heart catheterization. In terms of what I was going to do, we'll see if this works out. Oh, I think it may not be operational. So let me just go back. Sorry, I had a video, but I don't think it's going to work. So I'll just explain it. So what happens is that the catheter on the end of it is a pressure transducer. So it measures pressure. And they usually go in through the right around the elbow, and they thread the catheter very gently up through the blood vessels into the heart. And you can see is that they can actually, just with the natural flow of the blood in the pump of the heart, it actually will move the catheter up into the lungs itself, where we can measure the pressure. It's done as a routine outpatient procedure, a day visit. Sometimes they do a right and left heart catheterization at the same time, depending on what's being investigated, where they'll also look at the blood vessels that feed the heart. But this is the gold standard diagnostic test to confirm, A, do you have pulmonary hypertension? And if you do, the second question is why? So when we're classifying pulmonary hypertension, not to get caught up in terms, but pulmonary hypertension refers to any cause as to why someone can have high blood pressure in the lungs. When we're talking about the treatments that we have to give to patients that treat pulmonary hypertension, it's very critical that we're talking about group 1 pulmonary arterial hypertension, which is not everyone who has pulmonary hypertension. It's a select group that's actually quite rare. But I would say that in our clinic in Hamilton, probably about a third to 40% of the patients that we have in our clinic actually have scleroderma. And so it is critical to keep that in mind when we're assessing patients. The vast majority of patients referred to our clinic with pulmonary hypertension have pulmonary hypertension related to dysfunction or something going wrong with the left side of their heart. So this is that they have a history of arrhythmia, they have a history of diabetes, high blood pressure, high cholesterol, heart attacks, these sorts of things that can affect the left side of the heart. Scleroderma can also affect the left side of the heart, which complicates management sometimes. Similarly, if someone has very severe emphysema or COPD or uncontrolled sleep apnea, or they have pulmonary fibrosis, these can cause group 3 pulmonary hypertension related to the lung disease, in which case, again, that's not group 1 PAH. So it's one of the things that we do, and one of the reasons why we order all these tests is to categorize patients and classify them appropriately to make sure that patients are going to A, respond to therapy, and that it's safe to give them those therapies, because our therapies can often make these other types of pulmonary hypertension sometimes worse. And obviously, this is not a one-person show when you're running this type of operation. It's a multidisciplinary team. In Hamilton, I'm very lucky to work alongside Andrea Gardner in terms of our PH program to streamline the availability and care of our patients, but certainly collaboration with rheumatology. You can see many familiar rheumatology faces here, but also working with cardiologists, radiologists, and pathologists, amongst others, working in concert to optimizing patient care. So when we're talking about treatment of pulmonary hypertension, certainly if you are a smoker, it's a good idea to quit, especially if you have scleroderma, because of the associated heightened damage that can happen in that particular scenario. But also important, obviously, to get your immunizations all up to date. Exercise is something that, because there's an issue involving the heart and its ability to pump, sometimes there's a misconception that exercise is bad for you and that you'll damage your lungs if you exercise too much. That's actually not the case. It's important that you do exercise, try to keep your muscles as fit as possible. We don't want patients exercising to the point where they're having chest pain or they feel they're going to pass out, but certainly pushing yourself through a little bit of shortness of breath is fine. There's also dedicated pulmonary rehab centers across the country where that type of exercise and rehab can be certainly under direct supervision. In terms of the treatment options, also keeping an eye on our salt and our fluids, depending on how much fluid retention a patient sees. Certainly, we don't want them consuming multiple large Stanleys on a regular basis. We sometimes, for some of our more advanced patients, say less than 1.5 liters, but that's only if someone's in quite significant fluid retention issues and on high doses of water pills. But it's also really keep in mind of there's salt in so much of what we eat. And if it comes in a can or if it's won't go bad when not refrigerated, it's because it's heavily has a high salt content. So, and wherever salt goes, fluid goes. So keeping an eye on that is obviously instrumental. Oxygen therapy is something that some patients do need to assist with the symptom of breathlessness and also in terms of helping manage the pulmonary hypertension itself. Unfortunately, the inhalers that we have available to us in Canada do not usually work for treating pulmonary hypertension, so that's not something that will work. But fortunately, we do have targeted therapies that are effective in managing pulmonary hypertension. There's three major classifications of drugs that were traditionally available within Canada. The first group were the prostacyclins. Jane mentioned certainly in terms of uh, uh, their treatment with Remodulin. Remodulin is treprostinil, and it can be administered via subcutaneous or intravenous route within Canada. And in 2016, we had the oral prostacyclin agonist, Selexipag, that was also available on the market. We also have our endothelin receptor antagonist. This is macitentan or Opsumit, ambrisentan, or Voliberis, depending on what it's called. Bosentan is an older one that is used for this. And then we have our phosphodiesterase inhibitors that are Viagra or Sildenafil or Cialis or Tadalafil. They also have Revatio. There was so many different names for these medications. It gets a little bit confusing, but certainly there's these three pathways, and what we know is that these three pathways work well in combination together. Well, very often it's not that you're just getting treated with one drug; you're getting treated with two, three, and now as of 2024, we have a new drug available to us called sotatercept. And what's different than all these other drugs is sotatercept works by an entirely different mechanism, which we'll go through in a few slides here. And what was critical here is that this is a figure from a recent guideline statement that specifically looked at after initial treatment and initiation, in terms of if you see patients on subsequent follow-up and you determine that they're low risk in the green there, then they're doing well on their existing therapy and everything's going really well. And we use a number of different calculators to determine risk based on all the different parameters that we do, like a walk test, the echo, the blood test, how you're feeling, all these different variables go into it. In terms of when we subsequently evaluate patients over time, if they're not meeting low risk criteria, there is actually a recommendation that we consider sotatercept in those patients. So if you look at those three different boxes, this represents a large proportion of patients in Canada with pulmonary arterial hypertension. So if we think about pulmonary hypertension in terms of normal versus abnormal, in the normal case, it's sort of a balance of if you will, good molecules or good homeostatic, keeping the vessel healthy, which we'll call BMPs. And then you have your bad actors. And your bad actors are called activins. And there's this balance between your BMPs and your activins to sort of maintain the normal functioning of the blood vessels in the lungs. And when you have pulmonary hypertension, what happens is you have less or fewer of the good players or the BMPs, and you actually have more of the activins. And it's this imbalance that causes the core changes in the blood vessels that we see. And what's critical with sotatercept is these are actually an antibody that acts as a trap that binds the bad actor, being the activins, and it sort of acts like a mop and takes them away to sort of rebalance the good and bad players to help patients out. And there have been a number of studies that have been recently published in the last couple of years. We were fortunate enough to be involved in two of them here in Hamilton. And what the results of these studies show is that sotatercept improves long-term course. The initial trial looked at 24 weeks, but subsequently other studies have been done that looked at course over a period of years. Patients were able to have improved exercise capacity, improved heart function, and reduced risk of future progression or deterioration in their health. The Zenith trial, which specifically looked at high-risk patients and actually included a greater proportion of patients with scleroderma in it, this was a very powerful study. And what it actually showed is that treatment was associated with a reduction in the risk of hospitalization, lung transplant, and death, which is obviously a critical outcome in patients who were quite sick who were enrolled in that study. Side effects of the therapy is it can cause, because it's involving blood vessels, it can cause those telangiectasia, those abnormal blood vessels that are characteristic of scleroderma. It's actually a side effect of the therapy, and subsequently, as a consequence of that, there is some bleeding that can occur as a consequence of such. The drug itself is administered via an injection that you get every 3 weeks. Initially, you get trained on how to administer it in specialty clinics, but ultimately the goal is that you'll learn how to administer the drug yourself, and you will be on. And patients who are put on this drug, the goal when we start therapy is, unless there's an adverse event, is that you continue therapy long term. In terms of availability in Canada, it is Health Canada approved. It was just recently approved by the Pan Canadian Pharmaceutical Alliance, and right now we're just waiting on individual negotiations with the provinces with regards to price. The places where it's available is through the long-term extension phase of clinical trials of patients who are already enrolled into the clinical trials, and it's available through compassionate access from the company for those patients with the most advanced disease. The window for that compassionate access was closed a couple months ago because as time is going on, more private insurers are getting on board with therapy, and our hope is that in the coming months there'll be more widespread access for the therapy across Canada, which will be absolutely instrumental. And PHA Canada and Scleroderma Canada have both been critical in those initiatives. So the take-home messages for today are in the setting of scleroderma, annual screening with echocardiograms and breathing tests are critical to screen for pulmonary hypertension. And conversely, on the flip side of the stage, is that if you do have pulmonary hypertension, you need to be screened for scleroderma when you're initially at the time of diagnosis, and that involves a clinical exam as well as blood tests, including the ANA test that's so critical in rheumatology. Diagnosis and treatment is directed through specialty centers with multidisciplinary teams. And obviously, there's an evolving treatment landscape that is right now the major player in that is sotatercept, in terms of that's really changing the therapeutic landscape in Canada. And so I'd like to thank everyone for the opportunity here today. And I'm in Hamilton, and many people think of Hamilton as smokestacks and steel refineries, but Hamilton is known as the waterfall capital of the world, just because of our place along the escarpment, and as a consequence, there's some quite dramatic landscapes that are present. So with that, happy to take questions, and thank you.